Thank you.
Thank you. All right. Right, so hi, I'm Natalie. I'm one of the GPs at Great Chapel Street Medical Centre in Soho.
My name's David Woodley. I'm the ICN Care Navigator for Westminster.
So we wanted to just talk to you today about a project that's been running since about 2016, although it's changed quite a lot over the years, which is called the Integrated Care Network. And Dave's just going to give us a little bit of context as to why the project was needed.
Afternoon. So new research paints a picture of a society in which homelessness is growing rapidly and interactions between homeless people and the stretched NHS is soaring. Figures collated through a series of Freedom of Information requests revealed that the number of recorded visits to England's A&E departments by patients classed as having no fixed abode has nearly tripled since 2010-2011. During the last financial year, 2017-18, at least 31,924 patients visits were recorded, compared to just 11,000 7 years prior. In some parts of the country, numbers have risen by 5 or 6 times. King's College Hospital, NHS Foundation Trust, numbers are 15 times higher now than what they were. Recorded admissions from emergency departments to hospitals' wards have also rocketed, from 3,300 in 2010 to 5,000 in 2017-2018. Each visit to the NHS is estimated to cost the NHS around £148, and 1 day spent in a hospital bed is around £400, meaning these figures alone represent a bill to the NHS of more than £4.7 million. The Integrated Care Network, the ICN, is a collaborative project between Groundswell, Great Chapel Street Medical Centre, and Dr. Hickey Surgery. The aim of the project is to reduce A&E admittances and admissions to hospitals by increasing patients' engagement with primary health services and reducing secondary care. By navigating the care of targeted homeless or vulnerably housed patients for the 2 specialist homeless GP practices. The ICN caseload is up to 30 patients from both the 2 specialist homeless GP practices. I will be supporting patients to navigate their health appointments, providing practical support to addressing any barriers any patients may encounter with addressing their health. These barriers can be cost to attending appointments, remembering details of the appointments, and any anxieties around their health, to name a few. The ICN project also works in conjunction with Groundswell Homeless Health Peer Advocates, a peer advocacy service to support patients to attend health appointments. The primary focus being on assisting patients to navigate their health to a point that, where possible, they can navigate those services independently. ICN Care Navigator often involves liaising with a range of different services provided in relation to the healthcare needs of the patient. The ICN project is a health project commissioned by the CCG. However, patients with a social need are signposted to support providers to address many social aspects of their needs.
Just in terms of a bit of background of how the project has evolved over the years. So in 2016, it was originally set up as both a step-up and step-down project. So it was very much bed-focused. We'd managed to secure 11 respite beds across numerous homeless hostels within Westminster. And the idea of the time was that patients could have a maximum of a 6-week stay in one of those beds to either prevent them from going to hospital or to facilitate discharge from hospital. There were 2 beds which were deemed mental health beds, and they were sort of managed by our brilliant outreach specialist homeless mental health team, the joint homeless team. And there were 9 sort of physical health beds, which were managed by the 2 homeless GP practices. Over the years, it has evolved somewhat, partly due to the fact that we've had to lobby for the recommissioning and the money every year, and the need to obviously prove cost saving for the NHS. We know it does good work, but obviously that's not good enough. We need to show that it saves money. So really, they wanted to sort of make sure they were commissioning a service that addresses cost savings to the health service. And possibly, we've had to be quite persuasive about the idea of a service that addresses the social determinants of health as well. The CCG weren't convinced that the step-down aspect of the project was going to be cost-saving for them, because obviously it's more the hospital trusts that pick up I suppose the cost of a delayed hospital discharge. So unfortunately, it was sort of different parts of the NHS not really wanting to talk to each other in terms of funding. And also there was felt to be a duplication of mental health funding because certainly in our area, the mental health is a block contract with a sort of block amount of money paid for it. So they felt that they were sort of funding mental health provision twice. And then we had the very sticky issue of our patients with no recourse to public funds, and we were very, very disappointed when the CCG decided that they no longer felt that they could fund the bed spaces for people with no recourse to public funds. So the project evolved and has changed, and Dave's going to talk a little bit now about what the current model is as of April 2018.
So as Natalie says, the project changed significantly in 2018. The contract's now held by Groundswell. Health components are contracts held by the GP surgeries who manage and oversee the clinical aspects of the project. The care navigation role is myself, and I manage 4 beds across 2 hostels. As I said, and Natalie said, there's tighter criteria now to accessing the beds due to the changes last year. And we've now introduced a caseload aspect to the project. As I mentioned earlier, I have managed a caseload of up to 30 people. And they can also be high-intensity users, frequent attenders, to coin 2 different phrases that I've heard. And there's a lot of focus now around the caseload aspect of the service rather than just the health beds. So, the criteria for the beds. So the criteria is that a client/patient has a health problem that could lead to an admission in the next 4 weeks. And within the 4 weeks, their health can significantly improve within a 6-week period. So they're respite beds, short-term respite beds. Criteria for the beds, unfortunately, as Natalie mentioned, a patient needs recourse to public funds. That's one of the major changes since last year. And with no specific mental health component. There's a lot of talk today regarding dual diagnosis. We would try to work where we can and signpost, but no significant component. And also not a step down. This change from last year. We can't take referrals directly from hospitals to do step-down bed.
Criteria for the caseload is a bit more flexible. So referral to the ICN caseload is really based on complexity of medical need. And so I mean, they have to be registered with one of the 2 GP practices. They do not require recourse to public funds. They do not have to be rough sleeping. They can be in a hostel. They can be sofa surfing. They can be, in temporary accommodation or emergency accommodation. But really, it's us as clinicians identifying those people who have really complex needs, who really would benefit from that intensive case management and real sort of bringing together of sort of the care navigation, peer advocacy, intensive case management by our fantastic lead nurses at the practice, who actually probably should be giving this talk, but she just went off and had a baby. So yeah, shout out to Katie Baxter, who should be doing this instead of me today. And so we could probably refer most of our patients to Dave, but we do sort of cherry pick the most complex for that.
So the referral pathway, essentially there's 2 aspects we've mentioned to the ICN. There's the beds and there's the caseload. So there's some information on the slide of how to refer. There is the Groundswell website with a referral on there. That's on the screen, as well as my NHS email. So we take referrals from anywhere. If you're not sure about the criteria, because I completely understand, it's not the easiest to understand, please do a referral form. I work with you to see, even if we can't, I will signpost, I will try and give the best advice that I can. But even if you're not sure, put in a referral. So essentially, every client/patient will go onto the caseload first and foremost, because then on the caseload, I work with clinicians and I can decide of what is needed on the care plan in terms of their health. The beds are a tool that we use with the caseload. So a lot of the referrals I get are for beds, and that's understandable. I work in a homeless sector, a homeless GP practice, but we like to go for referrals to go onto the caseload first and foremost. So again, just to recap, on the caseload, clients do not need recourse to public funds for the caseload. And I have 30 that I work with, and I work with the clinicians to draw up care plans, and clients can be in accommodation or rough sleeping. So the ICM beds, it works in conjunction with the caseload. So often we'll have clients that will move from the bed to the caseload, from the caseload to the bed. So there's a slide coming up to try and indicate that people can go in more than once as well. But importantly, for the ICM beds, you do need recourse to public funds. So the practicalities, so like I just mentioned, is the dynamics between the beds and the caseload. As I said, we use the beds as a tool. So if we have someone on the caseload who's been on there for a period of time and they have recourse and we feel that respite into a bed will benefit them and benefit the health, we can move between the two. I would like to think that the care provided to either someone in a bed or on the caseload by myself and the practice is exactly the same. There is no difference between the two. So the beds, so as Natalie mentioned, they need to be registered at either of the two specialist homeless GP practices. We create a care plan for the individual around their health, and that's done by a clinician. I initially meet with them when they're in the bed and trying to build a relationship with them. What's everything everyone's been talking about this morning, integrated work, building relationships, and they liaise with hostels, including risk assessments. So many of the people that we come into the surgery, it's often we don't know very much about the person. So I use tools such as Chain and work with the hostels to look at risk assessments, but can be quite difficult, but the hostels are very understanding and work alongside them. Escorting patients to the hostel. So once the clinicians identified that someone will benefit from an ICM bed, I will accompany them down to the hostel, make sure they're booked in, they have everything they need, look at any kind of barriers to their stay. Often we have people into beds that haven't been in accommodation for a number of years, and it's understanding that as well. So as I said, the caseload is almost exactly the same. Visit to either GP practices, allocated to my caseload, create a care plan for the lead nurse, and needs assessment. I want to stress that exactly that is the caseload and the beds are almost identical in terms of the support that you will receive. Me again. So an overview of what gets done during a bed stay. So in terms of navigation, it's myself. I liaise with a number of support services, whether it's hostels, outreach and day centres. Care navigate through primary and secondary care, using the Groundswell HHPA to accompany to appointments. As I said, it's just myself. And I have a caseload of 30 and hopefully 4 people in bed. So 34 people with a lot of appointments, I cannot attend them all. So without the HHPA, I couldn't possibly support the client to all their appointments. So without them, the project wouldn't really work. Access to social needs. So my background is in homelessness. So I've worked in the homelessness for 9-10 years. So that I understand the social aspect of the health, but working alongside the clinicians, it works hand in hand. So I can signpost. I've worked in Westminster for a number of years, so I know the day centres, I know the individuals, and it's collaborative working with health and homelessness. Regular telephone and text appointments. I can put things on a slide and say how I do it, but how you articulate that is very difficult. Listening to the peers earlier, it's building that relationship, and it's speaking to a client or a patient on a human level, and not having always having an agenda when speaking to someone. I think it's important to try and paint a picture of how I build that relationship. It's very difficult, but things like daily contact, just a phone call and text message, how are you? How's your day? With no reason other than that, I think it's very important. It helps me build a relationship with the client group. As I say, many people we take on a caseload, they've never addressed their health. They've never been into accommodation, and building them trust is very difficult for individuals. And again, link up between support service, providing a 360 working group. And again, everything you hear today is all about integration and joint working. So a large part of my role is around that. Me.
You want me to do it? You want to do it?
That's okay. I'll get on a roll now. Outcomes measured. Everything's about money. Cost savings to the CCG. So this figure of 61,000 in 9 months. So I've been in post since March last year. In 2018, we had, I believe, 26 people, I believe, in our beds in 9 months. And we estimate that it saved the NHS £61,000 from just the people in the beds, from non-secondary care and being in the beds and saving the NHS. So EQ5Ds, I hate these terms. Clients report a 33% increase in quality of life at the end of an ICM bed stay. Personally, that doesn't mean much to me. There's a slide later that means a hell of a lot more to me, about quotes from people that I've worked with. But again, when it comes back to measuring outcomes to the CCG and funders, this is very important. So again, a term thrown around is frequent attenders, HIUs, to A&Es. Data sent to the CCG, we send data monthly to the CCG, that's anonymised, and they use a department called Descro, where they look at, is there a reduction in secondary care? And it's where we have frequent meetings with them, and across the board, they're very happy with the outcomes of reduction in secondary care of everybody on my caseload. And social outcomes. So we are a health service. We're not funded to do social work. However, our social outcomes are excellent, and something that I think is very important as well, because they go hand in hand.
I think it's worth saying at this point, Dave, how many people who've been in the beds who've gone back to the street?
Very few. Of the 26, I'm aware of 2 cases that they went back to the street. One was extremely complex, and one was free choice.
So just moving on to challenges. So the challenges that we've had with this project is that sometimes when we engage somebody and we get them in to see us, and we, get them maybe prioritising their health in a way that they haven't done before, obviously sometimes that increases their use of healthcare, which we think is great, but the people who give us money don't necessarily think that that's a brilliant thing. Obviously, we're trying to make that primary care rather than secondary care, but there are times when we see somebody who really has neglected their health and not been able to prioritise their health in a way that we do need to send them into secondary care. We think there are long-term gains for that being done in a more managed way. Obviously, no recourse to public funds is a massive gap in provision, and we are continuing to lobby the CCG and anyone else who wants to give us money to try and help with that. In terms of outcomes, it's quite difficult to prove a negative, so we're having to, obviously our outcomes are about proving that something didn't happen, and that, I think that's a lot of problems that we have within the homeless sector as a whole in terms of sort of what interventions we do and proving that would have happened had we not have made this particular intervention. It's really hard to end somebody's bed stay. As you can imagine, they've had a lot of intensive engagement, and although that engagement will continue because they will drop down onto the caseload once they leave the bed, but especially for those few people who will be going back to the street, it's awful, isn't it, Dave? It's
right.
Awful. But it has to be done, otherwise we can't get the outcomes, and if we don't get the outcomes, we don't get the funding. Risk assessments, we do have problems sometimes with risk assessments and getting them into hostels because not everybody is able to go into the hostel beds. And obviously long-term changes in the health service use of our patients, and the cost savings are not going to be recognised by us because our patients, are a relatively transient group, and so we have certainly at the surgery, we have a 50% turnover year on year, and so by the time there are those big changes, they're probably not registered with us anymore, and the sort of real gains are probably not going to be recognised in the short period of time that we're seeing them. Okay, strengths. But it's good. There are lots of challenges, but there's also a lot of good things. Collaborative working is probably one of the biggest things. Dave is super awesome, and he pretty much will chat to anyone and everyone, and he manages to just navigate all those cross-sector boundaries. He's in with the housing guys, and he's in with the hospital guys, and he's in with the patients, and he's in with he's in with everyone, and that's how it works. So that's really down to Dave. Case management, we know, is the gold standard. Multidisciplinary case management, we know from all the recent research that's the way to do it. Intersector trust and relationship building, and the patients really do love it, which will take me on to some beautiful testimonials that Dave has had over the last year.
Yeah, I mean, they speak for themselves. I can feed back to the CCG and give them EQ5Ds and God knows what else. But this is why I get up in the morning, and this is why we all work, everyone in this room actually. For the outcomes, they speak for themselves. They're very powerful actually. So yeah, there's not much else to say about that. So we go on to some case studies.
I'll run through these because I'm aware that time is short. So this is a very simple case of somebody that we put in a bed just to help put it into context. So this is a 52-year-old gentleman who had 4 recent, I think in the last 6 weeks, recent A&E attendances, although if you look back in his record, since 2013 he'd had multiple A&E attendances and non-elective admissions for IV antibiotics for cellulitis and an infected ulcer of his lower leg. He had a past medical history of brain injury, mental health problems, substance misuse, and he was rough sleeping, and he wasn't seeing a GP, and he wasn't attending primary care at all. So this is a great example of somebody we can put in a bed, because we know that elevating that leg is going to help heal his ulcer. It's going to help, being in somewhere is going to help him take antibiotics, linking him up with everything and getting somebody care navigating him is going to help bring him in for daily dressings. We also took the opportunity to wean him off some of the addictive prescription medications that he kept getting given in A&E every time because he was in agony. And we could also quickly access some mental health support from our wonderful in-house counsellor, mental health care practitioner, and psychiatrist, who all managed to see him within that bed stay. We did a lot of preventative stuff, blood-borne virus screening, vaccinations. Dave sort of navigated him to accessing housing and benefit assistance, and of all the medical appointments, which also included tissue viability for him. And the outcome of that?
Yeah, in terms of the outcome, I want to point out the fact that we've done this over a 4-week period. And the outcome, so the cost saving over a 4-week period, was £4,852 to the NHS. So since then, the gentleman is being on into temporary accommodation. It's the first time he's been in accommodation for a number of years. He has not had any A&E admissions or attendances since going into the ICM bed, what is huge compared to what his situation was before. Improvement in the EQ5Ds. Yeah. Mainstream regulation. So he's registered locally now to where his local practice is. So it's a mainstream GP. What may sound to some people like it's not a huge deal, but it is for our client group.
And then a very quick case demonstrating somebody who's on the caseload, and this chap is actually still on our case, on Dave's caseload. He's a 53-year-old gentleman who was placed into emergency accommodation in Westminster following a very extended hospital admission. He has Crohn's disease. He got 4-quadrant peritonitis following an operation. He has a stoma bag. He was malnourished and dehydrated, keeps getting acute renal impairment on the background of some chronic renal failure. multiple readmissions after, to hospital after discharge, and he was really struggling to manage his own care in the community. He was in a very low support temporary emergency accommodation, and he just wasn't able to take his medications, get to his dietitian appointment, and he just kept bouncing back to hospital. So we obviously popped him on the caseload, and because of the complexities of all of that, he had social services referral for his care needs. Dave, you prompt him all the time about his medication, don't you? Daily, don't forget your meds. And arranging sort of docket boxes and delivery of that to him because he wasn't managing to get to the chemist. Coordinating all his appointments. He has a lot of appointments. He's also got ankylosing spondylitis, so he has appointments for that as well. And he's still on the caseload.
He remains on the caseload, yeah.
He comes in for, we try and get him in sort of weekly reviews, but Dave and our nurse go and do home visits, don't you?
We do.
And you text him all the time.
He texted me about an hour ago.
And we did prepare these slides a few weeks ago, and I said, no A&E visits or unplanned. Unfortunately, I did have to send him in last week with acute renal impairment, but he didn't need admission, which was great, and he's doing a lot better. So just to sort of sum up, thinking about the future, and actually really to pick all the brilliant brains in the room, what other data can we collect? Because we don't have funding secured for the next financial year, which is worrying, given it's the end of March almost. I don't think we're going to be shut down immediately, but there's always a risk. What other outcomes can we measure, and what other data can we collect? CCG would like to have data for the caseload patients. Anyone got any good ideas about what we should do for that? The CCG are quite keen on the idea of it being collaboratively funded, so funding streams coming from maybe the local authority as well as Just Health. And also, we feel as though there would still be big cost savings if the needs of people with no recourse to public funds were met as well. Thank you very much for listening.
Cheers. Can you sit down? Thanks.
So one of the things that I find really fascinating, just hearing you speak, is that, in homelessness, we have so many gaps in our knowledge. Most interventions out there haven't really been tested thoroughly, but we do know that discharge programs deliver. Maybe you don't have that evidence for your program in particular, but there's plenty of evidence from across the world that shows that this type of work is worth investing in. So to what extent you've been able to, use those bodies of knowledge to make the case for what you're doing in the past. The other thing that strikes me is that it seems as if you've had to make compromises. And so I wonder, if you were to design the ideal discharge program, what would that look like? Because I'm pretty sure it would include people being 6 weeks on a bed. So could you say a little bit about that as well? And to what extent you feel, that dilemma of pushing back and being clear that if you're going to be user-centered, this is actually what you need to do versus, oh, let's compromise here, there, and the other, because this is how funding mechanisms are pushing us.
So shall I do the first bit?
I think our start, seeing it on the ground every day, there's a number of things. First and foremost, the elephant in every room at the moment is no recourse to public funds. It's my personal opinion that supporting someone who doesn't have recourse to public funds and poor health, it costs the NHS more money to not treat. That's a personal view on it that I see daily. I think step-down beds, as far as I'm aware, there are no step-down beds in London. I think that's a huge gap.
Certainly not in Westminster at the moment, although I know that Sam from Pathway, Sam Dorney-Smith, has done a big project looking at all the respite beds. And I think, there's a lot of research showing that there is great cost savings from step-down respite beds. I think it's about the funding streams. And the CCG is really, we're in massive financial difficulties when this project was set up. And so they really wanted to show cost savings to their own budget. Mm-hmm. And I don't want to make the commissioners sound terrible because, I think it's great that commissioners will commission a project like this. And I do think they should be congratulated for that. But yeah, the research is there. It's just gathering the data, I suppose, for our patients. We can gather the financial data and the quality of life data, but you know, every year they want more.
It's that difference between effectiveness and efficiencies. So effectiveness should deliver good value for money as well as impact for the patients, while efficiencies is where we tend to gravitate towards. So it's how we achieve that shift. Any quick comments from the floor, because we need to wrap up soon? No, we can't. Okay, we're going to do that later. Come on, we'll have the conversation, informally. Let's thank again our speakers. We've run out of time.